10 rhythms. Normal sinus, sinus braiding, sinus tech,
Yes, thank you.
A sip, a water, D-tech, L and SVT. So it's 8. On your rhythm strips. Oh, where's my laptop? So if you guys pull up your laptops so that I can kind of refer you to the slide.
What is it that you
This
want us
was
to
not
pull
working.
up?
I didn't realize that they had shut down the board and things that I went on meeting. But this is quick. Your dysrhythmia PowerPoint that's in your announcements. I mean, week 8. What's your normal heart rate? 60 to 100. And that's what we're gonna look at on these strips. If your patient is bradycardic, what's their heart rate?
Below 60.
Less than 50? I mean, 59, right?
Less than 60. Sinus tech,
Over 100.
greater than 100. So, when you're looking at a rhythm strip, please ignore my drawing because I'm not a good drawer. I'm gonna try. So you have your isoelectric line, then you have a P that should have like a little round hump. Down is your Q, up is your R, back down is your S, up, a little bit of a line, a T wave, and then it repeats. This is just one rhythm. You have a P, you have a Q, you have an R, you have an S, and you have a T. That's one. On your rhythm strips, you're gonna have multiple of these on that strip. So if this continued, and I have another P, and a T, that's 2. Okay? And it's gonna keep continuing. Look at slide.
Why can't we have class like this all the time?
I know. I know.
I just don't understand
Oh
how
my
much I miss
gosh.
this. My husband's like, you're happy, aren't you? He came and took me to lunch. I was like, oh, you just don't understand.
I mean, we can distance, like, if we're like this.
We work anyways.
Yeah.
So number 11. Look at slide number 11.
Where would we find it in our week-long?
Announcements.
Announcements. And it says week 8, dysrhythmia.
11. Okay.
Look at slide number 11. That's a 6-second strips. All of your strips will be 6 seconds. You'll get an EKG cap, that's a capstone. We're just hitting these hot topics. You'll be able to pinpoint these just by looking at them before you leave here, I promise. So on slide number 11, what we count are these waves right here. This is your R wave. So you count how many they are. Before you count them though, look right in front of it and make sure there's a P wave. So there's a P in front of every QRS. There's your T, there's your P in front of your QRS. Sometimes you may not have a T. It just kind of depends. But you should always find your QRS complex, look right in front of it for the P wave.
Well, can you point to your T?
Here, this is the T.
That's your T. Okay. Okay.
So we're not gonna learn about counting, none of that. I don't want y'all to know the measurements. You'll get that in the EKG class. I just need you to know what looks normal, what does not. This should be narrow. So if you look at those strips, they have like little small boxes. This should be less than 2 small boxes. You don't gotta measure it. You just look to make sure it's skinny. When it starts to look wider, there's something wrong. it's abnormal, right? So on your R, how you measure is R to R. Don't do this right now, I'm just showing you, because you're gonna do this in the EKG. If you don't have calipers, you take a piece of paper and you would like dot it here, and of course on your 6-second strip, it's not gonna be that big. But you go from one R to the next, and make sure they're evenly spaced. If they're evenly spaced, and there's a P in front of it, and those P's are evenly spaced, you do the same thing. You know you have a sinus rhythm. How do you know whether it's Brady, tachy, or sinus? You count them. So in that first one on 11, count those.
You count your R,
Mm-hmm.
right?
Count your R's.
8.
You got 8, multiplied by 10, your heart rate's 80.
Oh, wow.
Go to
Okay.
the one underneath it.
Right? I know.
You know, I
I
don't know how to read.
Go to the next one below it.
Okay. Mm-hmm.
60. So that's your heart rate. So which one of these rhythms is that? It's a normal sinus rhythm. We do
Both.
nothing, our patients. Yep.
Right?
One is 80, one is 60. One is between 60 and 100, you're in normal sinus. Okay? Now we're going to look at slide number 13, sorry. Do you see your R wave? Is there a P in front of it?
A tiny little P.
They're different.
So sometimes your P's are smaller.
So
Long
they
as
could be
look the
different.
same,
Okay.
as long as each of the P's look the same, that's what you worry about.
Okay.
Does each P before the QRS look the same? If
No.
it does, and your QRS, that's normal, that little small narrow piece, count 'em. How many you got?
40 heart rate.
Heart rate's 40, so what is that?
Brady.
Sinus bradycardia. If your patient has sinus bradycardia, their heart rate's less than 60, and they are symptomatic, so their blood pressure is low as well, they're hypertensive, they have dizziness, they have syncope,
This is if they're Brady.
yes,
Okay.
we're gonna give them a drug called atropine.
Mm.
Atropine will increase that heart rate. But if their heart rate is less than 60 and they don't have any other, they feel fine, we do nothing. Now, some patients are gonna be less than 60, so you have to know what their normal is. Your athletes are gonna be below 60. Sometimes when your patients go to sleep, they're not below 60. Sinus test. Look at slide number 16 on, is it 17? Can
Oh,
you find the
yeah.
P in front of that QRS? Your T is huge, but you see there's a P right in front.
Mm-hmm.
Count it.
The P's?
Mhm.
I thought we count the R's to get the
Count
heart
the,
rate.
yeah. So the P,
Yeah.
you can count the P's or the R's, it doesn't matter when they're both normal. The P is your atrial contracting, the R is your ventricle, and they usually contract at the same time,
Okay.
normally, until we get here.
Okay.
It's a little P, right?
It's a little P. Mhm. It's there.
Right.
How many you got?
140.
You got 14, yeah, 140.
Mm.
Greater than 100, sinus tech.
1, 2, 3,
Is your computer not working?
Mine? No, I just, it's loading up.
13. Why are you guys getting 14?
Did you count all your R's starting at the first one?
Well, I was counting the P's.
I mean, no, count the R's. Count the R's.
Okay, okay.
Count the R's. I always count your R's. And look for the P in front of that QRS. If
Okay.
there's no P there, then you don't have a sinus rhythm. You're gonna have something else.
Okay.
What slide are you looking at, sorry?
17.
17.
Okay.
So you got 14?
So if you have a P, you have sinus something,
Mhm.
right?
Yes.
Okay.
For your patients that have sinus tachycardia, we'll have them do vagal maneuvers to get that heart rate down. Sometimes you have to take a cold shower, but we don't normally give them anything for it. AFib is your next one. So the P is your atria. So anytime there's something atria, you're looking at a P wave. Anytime there's something ventricular, your V, you're looking at the R wave. Okay? That makes sense so far?
So the A is?
A is your P wave.
Okay.
There's your atria. Your atria is contracting, so your P
A.
wave is always gonna be atrial something.
That's your P wave.
Your R wave or your QRS complex, this whole little piece right here, that whole piece is your ventricular contraction. But we just always look at the R because it's easier to measure than the Q or the S. Okay. So an atrial fib, the heart is quivering. There's not a good contraction. If there's not a good contraction, you can't see that P. So your isoelectric line, and you'll see little waves. Then you see your QRS complex. Lines, your QRS complex. Squiggly lines with a QRS is always going to be AFib. Just squiggly lines. Oops,
Without
those
a
squiggles.
QRS?
If you see just squiggles, that's ventricular because you can't find a P wave in there anywhere. This is AFib. This one is VFib. Those are fibrillatory waves. They're small waves. So if you see fib waves, then you can find that in QRS, AFib. If you just see squiggles, you're in VFib, or your patient is. If your patient has multiple P waves before the QRS complex, whoops. P wave, P wave, P wave, P wave. You got more P's than you do QRS's, and your QRS is equally spaced out, so those are still regular. If you can match them up, and they're the same, if you go all the way across, but you got more P's, your patient has a flutter. These are called flutter waves. And sometimes they say they're sawtooth pattern. You can have either 2 beats, 3 beats, or 4 beats of flutter. Yeah, if you have, your QRS complex is supposed to be narrow, right? If you have one that is, those are not narrow at all, are they?
Mm-mm.
This is VTAC. So the difference between VTAC and VFib is the height of those waves. And it's gonna be a lot. And if it's tachycardia, how many of these are you gonna see on that 6-second strip?
Over 10.
More than 10.
So the tachy would be if you're not seeing a Q wave that's at all narrow, right? It's
So this would be your R wave, but it's rounded,
okay.
and you can't find a P. There's no P in there. There's a P somewhere, but because that ventricle is contracting so fast, it covers it. So you can't find it. So if you never see a P, if you cannot distinguish a P, then you know you got a ventricular something. The way I remembered it works for me, may not for you. Tall starts with a T, tachycardia starts with a T. That's how I separated ventricular tach and VFib. The taller, tall starts with a T, tachycardia starts with a T.
But there's nothing tall there. It is tall?
These are tall.
Those are tall.
These are tall waves, these are not. Your fib
Okay,
waves are not.
okay,
So
okay.
they may be close, like this should be your isoelectric line.
Mm.
Those waves can be like this, or they can be a little bit bigger. All of those would be VFib. For
Okay.
VTAC, they're gonna be tall.
Oh, okay. I see.
So
Okay.
those are taller than those
Okay.
are.
So that's how you remember
VTAC
VFib
and VFib.
versus VTAC.
So the
VTAC is tall.
Okay.
ventricular are always small.
Ventricular, you never find a peak. Ventricular, you will never see a peak. And if they're tall, it's ventricular tachycardia. If they're short, it's ventricular fibrillation.
So VFib never see a P?
Neither of those. If your patient has SVT, that is supraventricular tachycardia. That means that the heart has been paced somewhere outside of where it should. Somewhere in the ventricle, but not in the SA node, because the SA node is in your atrium. So if they have SVT, they may have a full, can't think of the name. They may have a full rhythm. So how your normal rhythm is with SVT, it'll look somewhat normal. It'll be greater than 150 most of the time. We're gonna give them some adenosine. So to get the SVT rate down, give them adenosine. If they got bradycardia and they're symptomatic, we give them atropine.
And the SVT, you said you're gonna be greater than 150?
Yeah. You'll look at that rhythm more when you get your EKG class. I just want you to know these basics. How many R waves will you have in a normal sinus rhythm?
6 or 10?
6 to 10. How many will you have in a sinus tachycardia?
Over 10.
Greater than 10. How many will you have in a sinus bradycardia?
Less than.
Less than 6. What is, this is my line. What is that?
V
V-tac.
tac, because
Is
they're
it tall?
little.
Is it tall?
No. Oh, VFib, because it's not tall.
Yes.
Okay.
What is, look, no, I can do that. Let me do this right. It would keep going, but. Say it again? Can you find your P's?
No.
If it.
AFib? Can
Flutter,
you
can
explain
see
that?
those P's.
So wait, why is that one? Can you explain why the second one is AFib?
This one,
Mm-hmm.
because those are flutter waves. So if this was going across. this-
Flutter? So is it AFib or
I'm sorry,
which one's
those
that
are
one?
This is AFib.
Okay, that's
These are-
AFib.
Yeah.
And why? Because you don't see your P waves?
Nope. So you have somewhat of a P,
Mhm.
but you look at the QRS complex. Now, if you just had these waves
Mm-hmm.
and none of this, what is that? VFib. So the QRS complex is what differentiates them. With VFib, you don't have a P wave. With AFib, you have your QRS and your P waves.
Okay.
AFib, VFib.
VFib. Okay.
What is, this is my line. Oops, no, sorry.
V-tacky.
Yes. V-tac, yes. If your patient has sinus bradycardia, so that heart rate is 54,
Mm-hmm.
and they are dizzy, and they have some nausea, and their blood pressure is 97/54.
Atropine.
How do we do it? Atropine, good. If your patient has SVT, their heart rate is 168, what do we give them? Adenosine, good.
Well, it's 168. We said it was gonna be below above 150. Okay, we're gonna give adenosine.
That's all you need to know with rhythms. That's it.
Okay. That's it?
That's it. That's all you need to know with rhythms.
Okay.
You get an EKG check class when you learn to measure and all that in Capstone. I don't want you to know the measure. I just need you to be able to look real quick and say, oh, that don't look right. And those are the 7 that if you ever work on a telemetry unit, you have to take a test. If you miss the VTAC and VFib or the AFib and A-flutter, they will not let you work it. You automatically fail. So you can get every other rhythm on that test correct, but you miss those 4, you fail. Cause those are your lethal
Most
rhythms.
common or what?
Those are the deadliest. So you
Mm.
have to know them. You have to get those.
Okay.
Okay. Don't forget those, cause at the end of this, we're gonna look at those again. Just to make sure you know. If your patient has VTAC or VFib, how do we get them out of that? Yes.
What?
We're gonna shock them. We're gonna
Oh.
do a defibrillator. She's back there.
VTAC. You shock?
Or VFib. We're gonna shock that rate. If we shock our patients, this electric activity going through the body, what can they not have on? Metal. No metal. No, my top one. Oh, it's way back there. I see it. Alrighty. Now, let's review. Y'all got questions on the rhythms? Nope. Okay, we're gonna start reviewing. Yay. Alright. Did you say you're hungry?
I thought that was a review.
It is. It's on the exam.
Okay.
But remember, we didn't cover it last week, so I
Right.
had to give. But yes, that was.
That was fun.
Let's just.
That was fun.
Yes. That's just one chapter.
Okay.
We have 3 others. Okay. Varicose veins. What are they? Varicose veins.
When your blood in the vein, like the valves are not working correctly?
Yes.
And it's like backflowing or not?
So they get kind of squiggly and wide. And so, what would be some signs and symptoms for patients that have varicose veins? So, pain in the legs. That's usually described as dull and achy. They can have swelling in those veins. They are at risk for getting DVTs or thrombosis. How do we treat our patients that have varicose veins?
Compression salt?
Yes.
I got my first pair.
All hard. You have them easy. All hard. Down.
Compression socks. How do we, what are you doing? Are you lifting your legs up or are you just
Stretching
switching
my
around?
legs, I've got
Okay.
thinking about salt.
So we're gonna do compression socks. So that's gonna add pressure and try and get that blood to go where it's supposed to because those veins aren't working. With the compression socks, how are we gonna have our patient's legs up or down? What's gonna help with that pain?
Up, probably.
Up. We're gonna elevate. Elevate legs. If they are having a lot of issues, a lot of pain, compression socks not working, elevating those legs not working, what's our next treatment?
Oral medication?
Sclerotherapy.
Mm.
So what is sclerotherapy? They use a dye, not a dye, they use an IV medication, they inject it into that vein. It causes that vein to dilate and it's inflamed and eventually it dissolves. So the veins will go away.
What dissolves the, what
The
dissolves?
varicose, the varicosity of the vein
Okay,
with sclerotherapy.
okay.
So we're gonna inject IV med. Will they have to be sedated?
Probably not.
Nope. It's done on an outpatient basis. We're gonna put those compression socks back on. And we want them walking,
We want what?
them walking.
Okay.
Walking helps to give you like a pressure to push that blood back up to where it needs to go to. When do you think these patients have the most pain? At night, why?
Because they're resting? Or after a long day of walking?
Because of the standing. So So standing up for long periods of time makes that pain worse. So they have their best or pain-free moments is usually best in the mornings. Venous insufficiency. Similar, insufficiency. And similarly to your patients that have varicose veins, for patients that have venous insufficiency, some of their signs and symptoms are gonna be the same. They're gonna have the pain in those legs. They're gonna have edema. And they end up with sores or ulcers. And where are those ulcers located?
Mid, not at the toes, right?
You were right the first time.
Mid,
Medial malleus.
yeah.
So on that ankle, on the outside of the ankle. If it's on the toes, that's arterial. If they have these ulcers, how do we treat them? I'm gonna treat these. I'm gonna do IV antibiotics, not topical. We always wanna put stuff on ulcers, don't do it. Don't put anything on these ulcers, no antibiotic ointment. You don't wanna put moist stuff on them, you don't wanna put dry. Sometimes you may have to cover them. The doctor may just wanna cover it just so that things don't get on them. IV antibiotics is gonna be, what we give you.
And how come, why wouldn't you treat like the wound locally?
So if they have an infection, cause that's why we're giving them antibiotics, right? Where's that infection at?
Inside and vein.
So what is put?
Right. Nothing, okay.
Let's see. So these patients too, just like those, they have more pain from standing. I think Ms. Autumn want you guys to know, venous diseases. Yeah. Other than IV antibiotics, what do we do to help our patients heal when they have these sores?
Send them to the wound care doctor.
Elevate, maybe?
But
chamber.
But bring it back a little bit before we send them way there. What are some things that we as nurses can ensure they're getting?
Pain medication?
Is that gonna help? treat
No.
it?
I don't know, elevate probably?
So always make sure these patients get protein.
What is it? Oh, protein for healing.
Uh-huh.
Okay.
Nutrition is huge with helping ulcers to heal.
Okay.
And if we don't have good protein intake, they are not gonna heal as well.
There's no DVT, right? Because of the edema now? No, this is something else.
No, this is just venous stasis, or venous insufficiency where the blood can't get back to where it's supposed to, and because it doesn't, they get sores. You
So
know,
it'll be
sores.
both legs swollen, right? Not just one.
Now it depends on which, if they only have one side, that's bad, then it could be one. It's not always both. For your patients who have heart failure. We're gonna heart failure, yeah, let's see heart failure. There's different types of heart failure, right? We have right and left. What lab do you need to check for heart failure?
For heart failure,
CK, MB, troponin, no.
that's for infarction.
So to check for heart failure, you need the B and P.
Oh,
And it will be greater than 100.
BNP. NP.
Then, we're gonna do a diagnostic test for these patients too, other than that lab. What diagnostic? We're going to do an echocardiogram. What does it look cardiogram strip?
Electricity, right?
The echo is a picture, it takes a picture when you're having the echo. The, you're thinking of the EKG for the electrical. So echo looks at ejection fraction. So your ejection fraction should be, for patients that have heart failure, is gonna be less than 55%. Normal people is about 55 to 70. That's where it should be. So if it's less than 55, that's significant for heart failure. The signs and symptoms. Your patient comes in and they have edema in the legs. Do they got right or left?
Left. Oh, in the legs. Right. Left is pulmonary.
Yes.
Okay.
So edema.
Right, edema.
Edema is right. That can be pitting and it can be dependent. If it's dependent, that means that you've got fluid pooling in places that it should not be. So for your males, the scrotum and the tip of the penis. For your females, it's gonna typically be in that labia. You can also get it around the eyes. So
So dependent means that it's localized to one area?
it's just pulling somewhere it
Pulling
shouldn't be.
some.
It's a pulling of. If your patient has crackles,
Left.
if your patient has shortness of breath,
Left.
if they have an O2 stat of 88.
Left.
So anything that has to do with oxygenation is gonna be left. If your patient has ascites,
Right.
if they have JVD, well, that vein is sticking it up.
Jugular vein distension.
If they have hepatomegaly, where the liver's enlarged.
Right.
So things that are going into the systemic area is gonna be right. How do we treat these patients with heart failure? What medications are we going to give them? We are gonna give them diuretics, good.
You said right is systemic, left is pulmonary, right? Lungs.
Left lungs.
Left lungs. Okay, and
So
we're gonna
use
give them.
some diuretics to treat them. So the main diuretics that we use are usually loops. So your furosemide, sometimes they may give them that HCTZ, and sometimes they give them both, depending on how much fluid they have. If you give diuretics, what is your priority concern for these patients?
Potassium.
So look at your potassium level. Is it gonna be high or low?
Probably low since.
Yes.
Oh, I have a question.
Decrease. Yes.
Calcium acetate decreases what?
Oh yeah, that. Oh yes.
Decreases phosphate?
Phosphate, calcium, or
We do calcium gluconate and,
No, the question
that
was
wasn't.
calcium phosphate.
There was two more
Calcium
options.
acetate, 667
And
milligrams.
one was pH plus.
Uh-huh. Does it decrease the pH? Does it
Do
decrease
we even learn
the
this stuff?
calcium? Does it decrease
The phosphate
the phosphate? And
or the glucose
Or the
something.
glucose.
Yeah.
Forget the glucose.
Yeah,
See,
that was.
that's
Those
it.
were the
I
four
put phosphate.
options.
I'm gonna have to ask Betty about that, cause.
We never learned that stuff though. It's like crazy, right? We
Yeah.
never learned any of that calcium.
So if your patient has diuretics, we're gonna be concerned about their potassium level. And we're going to, how do we know if our diuretics are working?
The patient's gonna increase urine like 10,
So we have increased urine output, so what else?
edema's gonna go down.
Potassium number orange.
So without even looking at,
Less signs and symptoms. I don't
so what
know.
is your, you-
Breathing better, less edema.
what about that word?
What?
The weight is gonna go down.
So weights and eyes and nose are
Weight,
gonna be your priority
weight,
nursing
working
interventions for
equals
these. We wanna do daily weights.
weight.
No more than 5 pounds in a week or 2
Eyes and
pounds.
nose. Yes. Hold that thought though, that's in our discharge teaching.
What did you
This
say
is a
before the
double.
weight? You said something before the weight. Did you?
No, daily
Okay.
weights and eyes and nose are how we're gonna monitor if this is working.
Okay.
Daily weights, eyes and nose. For your patients that were doing diuretics or diuretics are not working, we can give them another medication for heart failure. Yes, we're gonna give them digoxin. Thank you.
Along
What is your
with
normal digoxin level?
0.5 to 2.0. You're gonna give them the digoxin along with the diuretics if you see that the diuretics aren't working? Okay.
Some physicians start with digoxin before they do the diuretics because they don't always have the swelling and need to be diuresed, but if you see that they have the crack holes or here, I see.
Okay.
And short of breath, then we'll do the laces, but digoxin is your treatment. So with digoxin, we worry about toxicity. Toxicity is greater than,
2.
greater than 2 points. What are your signs and symptoms of ditch toxicity?
Brady.
Blurred vision.
Headaches,
Mhm.
blurred vision, nausea and vomiting, anorexia.
Mhm.
Those are your big ones. If your patient is taking this one and this one at the same time, how do our patients end up with ditch toxicity sometimes? Low potassium. So if they're taking both, you really wanna keep a close eye on that potassium level. Signs and symptoms, labs, meds, side effects of meds. All right. Discharge education. Now, DCED. If your patient's going home and they have heart failure, we don't want them coming back in the hospital if we can help it. So what do we teach them to do?
The nitro.
Daily weights.
Every morning at the same
Same time,
No clothes.
same amount of clothes. So no clothes works too, same, but I always want them to have the same amount of clothes on. What concerns you about that weight? We're gonna call the MD if greater than, how many pounds a day? 2 pounds per day, or how many per week?
5.
5 pounds per week.
Call MD if greater. 2 pounds.
What puts your patients at risk of having heart failure? The primary reasons. So you have primary and you have secondary. What are those 2 primary reasons?
Smoking, right?
That's the secondary.
Genetics, age, weight.
Kind of sort of, what y'all are saying, hypertension and coronary artery disease.
Primary risk.
Primary risk for heart failure,
Okay.
hypertension and coronary artery disease. I think that's all I want you guys to know about heart failure. It's a lot in there. Oh, no, it's not, almost.
Hypertension and hyper. Hypertension, right?
Yes, hypertension.
Hypertension and
Coronary artery
coronary
disease.
artery disease.
So part of your discharge education with your patient is gonna be on nutrition. A lot of these patients, any of your heart patients are gonna be put on the DASH diet. What does that include? How much sodium can they have?
Very little.
2 grams of sodium.
2
The
grams.
sodium holds on to fluid.
A day?
2 grams a day. So they need to learn how to read labels. They need to eat fresh fruit and fresh vegetables. Fruits, vegetables. depending on physicians, but for most of our heart failure patients, we are gonna decrease their fluids too, so put them on fluid restrictions. We want them to no fried foods. And fish at least twice a week. And one more, no canned foods, cause they are high in sodium.
So what is DASH stand for?
Can't remember.
Sodium. What is it?
Yeah, I don't remember, sorry. Me and acronyms are like this, man. Y'all got all of this?
Mm-hmm.
Yep.
Yep.
Are we the only one in the building?
Yep.
That's a little weird. I
This
mean,
is how it is when we were in class too, I was always the last one here.
I'm glad.
Alright. Your patient comes to the emergency room and they're complaining of chest pain. What's another name for chest pain?
angina.
Yeah.
Is it angina or angina?
Depending on where you live at.
You say angina, I'm like, I thought it was angina.
Yeah, it depends on where you live. Some people say angina and some say angina. It's the same thing.
Angina.
It just depends on where you are. I'm southern, so for us it's angina.
Mm.
In South Carolina. Same thing. So this is not a disease, this is a symptom. This is just chest pain. So what's the first thing you wanna do when your patient comes in with angina? Do you wanna do nitro first?
ECG.
EKG or ECG? It's both.
You're gonna do that first?
Mhm. That's first.
Oh,
Why?
there was a
Even though
question
they're
on
like
the
holding they're in pain, you're gonna do an EKG?
What does this tell us?
Okay.
What is an
What's
EKG?
going on?
So
Right.
we need to know, are they having an MI?
Okay.
Because if they're having an MI, door to cardiac cath lab is
90
90 minutes.
minutes.
So first thing we wanna do is look at the.
If they're
EKG.
having, repeat that? If they're having an MI? Right?
Yes, if they
Okay.
have an MI, door to cath lab is 90 minutes, but we're gonna get to that in a minute.
Okay.
There was a question on the exam, and it was, the patient already has a nitro patch.
Mm-hmm. It's been 30
The
minutes
patient already has a nitro patch, but he complains
after 30.
of chest pain. What would you do? Would you administer the PRN dose of nitro? Would you put on a second patch? Or will you tell the patient, wait 30 minutes and the patch will take effect?
We'll give us some medicine. Because if they're having chest pain, you wanna give them the sublingual.
Right.
You don't do the patch, because it works faster, the patch it takes a while.
Or move the patch somewhere else? It was fine.
That's retarded. So, they do the EKG. The EKG comes back normal, or it doesn't have any ST elevation, it has no non-ST elevation. What's next with our patients that have chest pain? What are we gonna ask them?
How long?
How long? So you gotta get the quality of the pain, how long they've had the pain, all that good stuff with your pain. It started this morning. So doctor said, okay, let's give them nitro. So nitro is gonna help with that chest pain when they're having angina. How many can we give?
5 minutes
Doses.
apart, I think.
But by
5
the-
minutes apart.
By the second one, before the second one,
3
You're gonna
doses.
If you're home.
okay,
If you're in the hospital,
we can do 3.
we're gonna, go up to 3 doses, 5 minutes apart. So, they're at home and they have it, we're gonna do 1 dose, doesn't work, call EMS. What do we tell our patients to care for their nitro? What do they need to do?
Dark vial.
Dark, cool place.
Yes. Dark container, keep it out of the light. Dark container. Cool.
It comes in the back.
And look at the expiration date. I always want them to fill those prescriptions before they medicine expires. However, if it has expired and they're having chest pain, they can still go ahead and take one.
Okay.
We want them to replace it before it gets to that point, but for whatever reason, they haven't had chest pain in 6 months and it expired last month, go ahead and take one and call EMS.
So would this have
What-
to work with some like prescription for a person, or could like I was asking you once in class on the lecture, like,
You said
would
when
that
they're
help
listening,
if someone was having like a heart attack?
well, how do you know though? We don't
Was
just
it
do it
like,
just
oh,
because.
the pain, or you could, you
We
describe
don't wanna
it as
just give them
pain in your
nitro because they're
chest.
having
Yeah.
chest pain. Now,
Yeah,
at
I'm
home,
sure
our
about it.
patients can take aspirin if they're having some chest pain to open up arteries if they have them. But we don't just wanna give them nitro.
No.
So with nitro, what does nitro cause in our patients?
Vasal, dilation,
Uh-huh, and because they do vasodilation, that blood goes rushing,
and you get a headache.
headache. Nitro causes a headache. What are we gonna take? Give them Tylenol. They still gonna take that nitro, give them some Tylenol. What are you concerned with when you give nitro? What are your nursing considerations? Besides the headache? Why? That's what I want, hypotension. And. This one is special though. Nitro can drop their heart rate pretty quick. Check the heart rate, and when our patients are going home, we're gonna teach them to check their own heart rate. If their heart rate is below where? Below 60, we're concerned, we don't give. Too much trouble. Say your patient come in and complain of chest pain, they have an EKG done, then the doctor say, I think they're having an MI. This EKG looks suspicious. What other things are they gonna do to diagnose an MI?
The cardiac enzyme
Name them, you started.
That's your
CM,
CKMB, your troponin.
CM,
Mm-hmm. Okay, so
and,
those labs.
blood.
So troponin, you can have troponin T or troponin I. Some doctors just say a troponin. This one is your most, gives you the
Oh,
most information.
wait.
You
Can
want the
someone
bonus?
else start it now? Mine's about to turn off.
Uh-oh.